Hi, my name is Jennifer Branch, and I'm a transplant coordinator. I'm here to talk to you today about kidney transplant. I'm very excited to be here and to be able to talk to you and give you all this information. I am a nurse. I graduated in 1996 from a diploma school of nursing. I've completed my master's programs. I'm now going back for my doctorate. I've worked in hemodialysis. I've worked in transplant since 2000. I've also worked for the National Kidney Foundation and a little bit in disease management for people with kidney disease. I also have received a kidney transplant from a deceased donor in 2014. So I'm very, very excited to get to tell you about all of this information. So kidney transplant is actually an operation, and it just replaces healthy kidneys. It actually does not fix the kidney disease that caused your kidneys to fail. The first kidney transplant was actually done in 1954 in Boston between siblings. And that has actually been many, many years that we've had to perfect drugs after transplant, the operation. There have been so many transplants that have been done since that time. So just want to let you know that the center that you go to has done many transplants, and you're going to be in really good hands. Transplant kidneys are very, very important. They allow us to do almost everything that your kidney that you were born with did before you had kidney disease. It'll actually filter the waste products from your bloodstream. It'll actually help with fluid balance, acid-base balance. Actually will help with hormones like erythropoietin that help with red blood cell production so that you should not be anemic anymore after transplant. It'll help keep your bones healthy with calcium and phosphorus balance. And so all the things that we really would expect a healthy kidney to do is just like before the kidney ever became diseased. Successful kidney transplants are very successful. Usually if you have a living donor, then those kidneys will last a little bit longer statistically from deceased donors. Getting a preemptive, which actually means getting a kidney transplant before you ever have to go on dialysis, that actually will give you a better success rate as well. I want to really spread the word and let people know many times over, we'll try to say this in this talk, that you can get a kidney transplant before you ever have to start dialysis. So how do you go about doing that? If you are talking to a kidney doctor, a kidney specialist called a nephrologist, then you really want to start talking to them before you ever go on dialysis about options of transplant. Whenever they're doing your labs and your kidney function measurements, we want you to know that you are eligible to get a kidney transplant whenever your kidney function, which is measured as an eGFR, whenever that level gets to be 20 or less. Dialysis actually doesn't start until your kidney function gets to be about 10 to 15%, so you do have a very good window of time to where you can get started on a kidney transplant evaluation and hopefully get listed or a living donor transplant before you would ever have to go on dialysis. So statistically, kidney transplants do last a very long time. At 1 and 5 years, it is anywhere between 97 and 74%, depending on if you have a living or deceased donor. At 10 years, if you have a living donor, we expect the kidney to last approximately 60% of patients to still have their kidneys working. So kidney transplants can last longer than 10 years. These are averages, and we're taking into account all people who have the kidney transplants, whether they had other comorbid conditions or other diseases or not, and everyone is being compared together. So if you're feeling like the transplant success rates are something that you're very interested in, you actually can go online. SRTR data is one of the websites that you can look up for kidney statistics at transplant centers all across the United States. So I want to tell you a little bit about how you go about getting a transplant. You actually can go online and look for a center at srtr.org. There are transplant centers listed all over the United States, and you just choose which organ you're interested in for a transplant. You actually have to be accepted by an organ transplant program and be listed before you can actually get the transplant. And sometimes patients just don't know that. Sometimes they think that as soon as they call the center or as soon as they talk to their doctor about a transplant, then they're automatically placed on the list, and that's actually not true. There are several tests that have to be run and some education that need to be done before you actually can be accepted to be listed, and so I just want to make sure you understand that. Again, you can get transplanted before your kidney function gets to ever needing dialysis. So whenever your kidney function or your eGFR became 20 or lower, talk to your doctor if you're interested in kidney transplant. You can be listed in more than one area of the country or more than one center at a time. And the advantage to doing that is that the actual transplant center where you live will start accumulating time and looking for kidneys for you in their local donor service area. And then additional centers where you're listed, they actually will also start looking for donors for you in their local donor service area. And so it almost acts like you're living and residing in two places, and you will actually get some priority in every place that you're listed. Now, there are a little bit of a disadvantages or barriers to being listed in more than one center. It's just travel time, and then you do need to go meet with the centers and the team. So sometimes that can be a barrier and sometimes not. If that's for you, please look into it. If you are a diabetic, you can ask your team about a kidney pancreas transplant. Generally, that is for people who don't produce any more insulin, and that sometimes is type 1 diabetics, but please talk to your doctor. Don't just rule that out as an option. So just letting you know one more time that you do have to be evaluated at a center, testing done, and accepted by a transplant program before you can be put on their waiting list. Things that actually can be barriers to transplant are if a person would have severe vascular disease, if the surgeons don't have a very good area in the blood vessels to sew in a kidney, if you have severe heart disease, severe liver disease, if there's any kind of an active infection or cancer, then those actually have to be dealt with before you get transplanted, because you're going to be on lots of anti-rejection medications that will lower your immune system. So we can't have any active infections or cancers at the time of transplant. This is center-to-center guidelines, but morbid obesity is sometimes a contraindication. It will actually depend on your surgeon and your team, and they will tell you if there's any weight loss or any barriers with obesity. Other things that can keep you from getting listed for a transplant would be active drug use, heavy alcohol use, or if you had tobacco use. And that will vary from program to program. Please talk to your coordinator. If you have any uncontrolled psychiatric illnesses, that might be a barrier to transplant. If you don't go to all of your dialysis treatments for one reason or another, if you don't take your medications, that is something that can give the transplant team an indication that you might not be taking your medications after the transplant is prescribed. So being adherent with your treatments if you're on dialysis and taking all of your medications is very important as well. One of the very important things for transplantation also is that you'll have to have enough resources financially to be able to pay for your co-pays, to be able to pay for gas money, medication co-pays, as well as visits to the doctor and lab visits after the transplant. So things that can actually help for getting a transplant is to call or email or get online and look at each transplant center's acceptance criteria so that you'll know that in advance. Also, you can call them and ask their coordinators about different acceptance criteria. Make sure that you stay as healthy as possible before the transplant. We want to make sure that you have very good exercise capacity and you're in the very best shape that you can possibly in before you get your transplant and on these immunosuppressive medications. Things to help you keep healthy while the transplant is to avoid people with colds and flu, anybody with active infection, and make sure that you do very frequent and thorough hand washing. If you are obese, make sure that you exercise and try to lose weight. If you're a smoker, please stop smoking. And then also just trying to make sure that you've exhausted all of your resources if you have any potential at all for a living donation option. We'll talk about that in just a few minutes as well. If you do home hemodialysis, that can also help to get a transplant, just showing the team that you're able to take care of your medications and to take care of your medical regimen. And avoiding blood transfusions if at all possible. If it's a life-saving blood transfusion, you want to talk to your doctor about that. Let them know that you're trying to get a transplant. And if that is unavoidable, then that's fine. Just make sure you talk to your doctor about that ahead of time. Donated kidneys actually come from deceased donors and from living donors. So deceased donors are from a waiting list. It's a national waiting list. Whenever people have signed their donor cards, whenever they've talked to their families about their wishes after their death. And it also can be from a stranger or someone who is considered a deceased donor, but they are actually directly donating to a specific person on the waiting list. Living donation actually can happen from a blood relative, a spouse, a friend, someone that you have some kind of a connection or a relationship with. It also can be from an anonymous living donor. So just want to let you know that there are several different ways that you can get a kidney transplant. Paying for the transplant on living donation actually happens from the recipient's insurance. Mostly for surgery, any follow-up directly related to the living donor surgery. If there's any health problems after and not related to the living donor surgery, then that is actually billed to the donor's health insurance. On the recipient side of things, we need to make sure that you also have very good health insurance coverage. That can either be through work, as a spouse or dependent, through an individual plan, Medicare Part A, which must be in effect the month you get the transplant in order to have Medicare Part B to ever pay for anti-rejection meds. Or it can come from Medigap plans and or Medicaid can help pay for the cost. So I want you to know that there's lots of different options. You do have to have good insurance plans in place before you're ever listed and before you ever get a transplant, whether it's a deceased or a living donor option. So who pays after the transplant happens? Well, Medicare actually pays, but just for 36 months if you only have Medicare simply because you had a kidney transplant. If there's no other reason why you have Medicare, then that coverage will actually go away after 36 months. So you need to make sure that you talk to the transplant financial coordinator at your transplant center to know when the Medicare coverage will end if you have that. After that coverage ends, you could actually use employer-sponsored health plan. Options besides an employer-based health plan include individual plans that could be on or off the marketplace if available, and we can go to healthcare.gov to get more information about that. But please really exhaust all of your resources and get good answers from your transplant financial coordinator so that you'll know before and after the transplant how you're going to be able to pay for these drugs, these office visits, these labs, all of the transplant care that will be involved. Tissue typing. I want to tell you just a few definitions and terms that we're going to go into next. And these are really important with transplants. Not really anything that you will hear about before or after transplant, probably too much, but it's really important for you to understand. So antigens, they're actually when your body, when your immune system sees things as foreign, as not yourself. And that could be anything, whether it's a bacteria or a virus, whether it's pollen from a bee, whether it's a transplanted kidney, anything that's foreign. Now we'll switch and talk about antibodies. Still dealing with your immune system, but whenever your immune system encounters something that is not you, then it will develop antibodies to fight those foreign things. We also want to talk a little bit about genetics. Human leukocyte antigen, those are different sites on your chromosomes. Your blood test will actually tell your transplant team what your genetics are, what your HLA testing is. Again, not something that you probably would have heard about before transplant, but it's very important for matching purposes and transplantation. And then also talk to you about PRA, or panel reactive antibody. So this actually stands for basically a percentage of how reactive your immune system is going to be fighting off a kidney transplant or fighting off something that's foreign to it. So let's pretend that you had a blood transfusion. That is something that is foreign, it's not yours. So whenever we check your PRA level, then you could have 0 to 100, just getting one blood transfusion. You could have a PRA level of 10 or 20 or 100. These are just a quantitative amount of how much antibody your immune system has reacted and how much it's reacting against that blood transfusion. And PRAs are it's very hard to know whenever a person has a pregnancy or a blood transfusion or a previous transplant, how reactive your immune system is just going to get. It's not something that's easily predicted. So, again, not something that your doctor's office would have normally checked on you. When you get a transplant, it's very important to know how reactive your immune system is. The lower your PRA level is, the quicker sometimes people can be transplanted. And conversely, if you have a high PRA level, if you've had many, many blood transfusions, you've had a previous transplant or two, if you've had many pregnancies, then that PRA level can be higher, up to 100%. And that actually would mean that it could be a little bit longer for you to get transplanted, just meaning that your immune system will not just accept any kidney. It's going to be picky. So moving on just a little bit, I want to tell you next about blood types. So it's very important that you get a blood type that is compatible with you for a kidney transplant. If you are an O, you are so generous. You are a universal donor. For kidney transplantation, unfortunately, you're not a universal acceptor. So people who are blood type O, and the positive and negative does not matter, Rh factor is what that's called, and it does not matter in transplant. People with blood type O can either accept from another O, or they can also accept from a special kind of an A called an A2. Now this is a relatively new concept. It actually goes back to about 1985 that was developed here in the Midwest. And we're very, very, very excited about this because it allows more people to be transplanted. And so if you happen to be a blood type O, you can get a kidney from another O, blood type wise, or you could be able to accept a kidney from an A2. Sometimes it's also called a non-A1. So if this isn't really being talked about for you, please ask and just make sure that you're being considered for all options. If you happen to be a recipient of AB, you are very lucky, because ABs are the recipients that can actually get a kidney transplant from any blood group, blood type wise. You still have to have other tests that will match and everything that will pass, but blood type wise, you are the universal acceptor. I actually use myself whenever I do talking and things, and I am a B. There are not as many Bs in the population. There's only 15% of the population of being Bs. And that's actually where A2 blood grouping came into play in transplantation, just to make sure that people that were disadvantaged as a B had more opportunities access for a transplant. So as a B, you can get a kidney from an O, you can get a kidney from another B, or from an A2. So please ask your transplant coordinator and doctors what your blood type is. Many times it's not already been done. And then that way you will kind of have an idea preliminarily of who you might be eligible to get a kidney from. Cross-matching is also very important, and this is again talking about your immune system reacting. So cross-matching just means that you actually have your name come up for a kidney transplant, then samples that are in the laboratory of yours will be mixed with samples of the potential donor. And we want to make sure that there's no antigens from the donor that your blood recognizes as foreign and attacks. So basically we're just making sure that in a test tube, your blood plays nicely with the donor's blood before we actually give you the kidney transplant. We want to make sure that that cross-match is okay. And the way that we use the terminology is a little bit confusing, because if the blood clots or does not play nicely together, it's actually called a positive cross-match, and that is a bad result. If the blood plays together nicely and there's no clotting, then that is a negative cross match, and that is what you want for a kidney transplant to happen. There are some myths that I want to make sure you understand are not true about kidney transplant. Kidney transplant does not actually cure your disease that caused your kidney disease in the first place. And so talk to your doctor about that. There are just a few rare types of kidney disease that can reoccur in kidney transplantation. Just talk to your doctor so that you'll know ahead of time if that's the case. But transplant is actually another treatment like dialysis. It is not a cure. Also, we want to make sure that there's no really age cutoff for kidney transplant. This is very individual acceptance criteria at each center. It's really generally what your health status is, not how old you are or a specific age. Sometimes people also think that you can move up higher on the list. Like today I'm number 100, tomorrow I'll be number 99, the day after that I'll be number 98, and that's actually not how the transplant waiting list works. There are a lot of different factors that go into play. It's a very complex algorithm that includes your blood type, how long you've been waiting on the list. It includes a lot of different things, your PRA, your antigens, your HLA. So all of that goes into effect on the transplant waiting list. That actually works with your location of where you live and reside. If you're listed at more than one transplant center, that is actually taken into consideration. Also, your blood type, your antibody level, your match, antigen-wise, what the antigens or what's considered foreign of your body with the donor's antigens and antibodies, that is all looked at as well. The waiting time, and this is really exciting that in 2014, waiting time actually starts from the first date of dialysis. So while we really encourage you to get transplanted before you ever have to start dialysis, if you have already started dialysis, that's okay. As of 2014, you will actually get credit for every day that you've been on dialysis. So whenever you're listed, it'll actually take that in consideration, and the time will go back to the first date of your dialysis. Also, if you happen to have been an organ donor before, either kidney or section of liver, then that actually gets you points on the waiting list as well. Things that also come into play on how you will get a transplant off the waiting list is the donor health of the deceased donor. And this is actually a score. It's called a KDPI score. Ask your transplant center about it. It actually includes things like the cause of the donor death, the creatinine at the time of the death, if they had hepatitis C or not, their height, their weight. There are many different factors that go into that score. And they try to look at both donor considerations and donor measures and recipient measures to see how long the recipient might live and need that working kidney. So all of that goes into how the waiting list works from the donor and recipient side. It's very complex. After hearing it from this one time, you probably will not remember everything. So please ask your transplant center and your coordinators and read as much as you can about how the transplant center waiting list works. So I mentioned before that there's a lot of different tests that have to be done before you can be listed for a transplant. And this varies just a little bit by center to center, but for the most part, we do have to check your ABO blood typing. We do have to check your HLA, which is your genetic markers, and your PRA, which kind of tells us again how reactive your immune system is. We also have to have our doctors do a physical exam and history on you. A chest x-ray is almost always required, as well as some type of kidney imaging. We need to look at your blood vessels, your kidneys, make sure you have enough room to place a new transplant. We'll have you do lots of urine and blood testing. Many centers will require that you have at least an EKG and an echocardiogram, if not more, like a stress test or a cardiac catheterization. You will have to have a dental exam to make sure you don't have any active infection or cancers in your mouth. You will have to have a psychosocial assessment, And then we do have transplant financial coordinators that will make sure that your insurance status is up to date and make sure that you're well informed before and after the transplant about resources and financial considerations for the transplant. A lot of times, a lot of these tests have to be repeated annually. This will also vary according to each center. So when you first get called in for the transplant, I want to let you know a little bit about what's going to happen when you get called into the hospital. Whenever you're first admitted to the hospital, they're going to be doing lots of testing on you, like chest x-ray, EKG. They will probably do a lot of blood and urine lab work. You'll visit with anesthesia personnel. I want to let you know about the surgical incision that you're going to have while you're in the operation. It almost always goes in the right side of your lower abdomen, and that's going to be a pretty large incision, like 8 to 10 inches long. So just letting you know about that. They do the transplant in the front. They actually don't remove the kidneys that you're born with, almost always. In rare instances, they will remove them. You'll either have staples or you'll have dissolving stitches for that transplant incision. Almost always people are in the hospital for 5 to 7 days. If there are complications or if the kidney doesn't start working right away, it could be longer than that. We want to make sure you understand recovery is going to be kind of a long time if you're a very active person. It's usually about 4 to 6 weeks, depending on what type of work you do or how active you normally are. If you're a person that works around children or in schools or in hospitals, if you have lots of exposures to germs, then that may be a little bit longer because you're going to be on anti-rejection immunosuppressant medications. So the hospital length of stay can vary. It's just going to depend on if you have any complications or not, and then also what center and what their protocols are. We talked about this just for a second, but I want to remind you that the new kidney almost always goes in the lower right part of your abdomen. If for some reason you can't have the kidney on the right side, then they will put it on the left as long as your blood vessels are healthy on that side and that there's not any other problems. So the kidneys that you're born with, higher up in your back, those are almost always left in place unless they're actively infected or they're causing pain or if there's not enough room to put in a kidney transplant. So after the kidney transplant, there's some very, very good things that can happen. And then there's also some things that aren't as great, but they get better. I want to let you know that you're going to have a different diet. You're not going to have to watch your phosphorus anymore, potassium anymore, as long as that kidney is working right away. Fluids are much better than dialysis if we want to compare it to dialysis. The medications actually are going to be a little bit on the worse side because you're going to have the most medications after the transplant that you will ever have at any time after the transplant. So right whenever you're getting out of the hospital, you'll normally have about 15 to 20 new pills a day. And that is a lot of medications. Those get better quickly. So I just want to let you know that the amount of medications, the dosages that you take are the highest when you first get transplanted and then get better as time goes on. Pain-wise, you will have pain. You will probably have mild to moderate pain in the area of the transplant incision for at least 3 to 5 days after the surgery. You will get sent home with pain medication. Just ask your doctor. Make sure that you take it on a regular basis so that you don't get really, really bad pain that can be avoided. Make sure that you tell your doctors and nurses if you are having really, really bad pain or swelling in the transplant incision area after 3 to 5 days. You will have lots of return to clinic visits. And this is, again, very, very extreme at the very first part of getting your transplant. I always tell the patients that it's worst at first, but it definitely gets better. If you can get through the first 3 to 4, 6 weeks after the transplant, it gets so much better. So we're going to have you return to the transplant clinic and get labs very frequently after you get transplanted. And that lasts for probably the first 2 to 3 months. and then you get to go monthly or less after that, depending on your transplant center's program. So ask your doctor and your nurses when it's okay that you can exercise, when you can return to work, when you can get pregnant. Please talk to your team before you are making big decisions like going back to work. You want to make sure that you're doing the very best thing for the health of your kidney transplant. A lot of people after transplant will also have some emotional ups and downs. This is a very, very important time in your life when lots of things are changing. You're on lots of different medications, namely prednisone, which is a steroid, and that can really make you feel like you're on an emotional roller coaster. So talk to your team if you're having any kind of emotional ups and downs. It's very normal for that to happen, and you just want to make sure that you let them know and that you can have someone to talk to. There are potential complications that can happen after a kidney transplant. We want to make sure you're aware of this. The kidney may be slow to work after kidney transplant. That's called delayed graft function. That can be very quickly to resolve, or it could go on for weeks. It could be that it makes you have a need for dialysis, or you may never need to do dialysis. So talk to your team if it looks like your kidney is not working right away. Sometimes the kidneys can be slow to work. They can almost like they're in shock after the transplant. So that's not what we expect, but it is a complication that can happen. The kidney can be rejected by your immune system. Even though we did cross-matching, there's a lot of different things that can happen during the actual organ retrieval and during the transplant operation that your immune system can react to. And so there is a very, very slight chance that you can have a rejection episode. And the team will be watching your labs every day, at least once a day lab draws while you're in the hospital. So we just encourage you to talk to your team about how your kidney function is doing and to know your numbers. You could have a problem with anesthetic. If you're a person that already knows that you have problems with anesthetic, make sure you tell your team that whenever you meet with your transplant team. You could have an infection. Again, we are suppressing your immune system big time after transplant. And so it's just making you at a higher risk for developing or catching an infection. So make sure that you're doing lots of hand washing and staying away from people that are ill. You can actually have, this is again very rare instances, but you could actually get an infectious disease from the transplanted donor kidney. Now we do lots of testing whenever we're doing deceased and living donor transplants. Testing such as HIV, hepatitis A, B, and C, syphilis. So we want to let you know that we are doing lots of testing, and occasionally in very rare instances, there can still be cases of infectious disease through a kidney transplant. You could have bleeding or transfusion need if there is some kind of a complication in surgery. You could have a blood clot. You could have drug toxicity, which would just mean that one of your anti-rejection medications is very harsh on your kidney when you first get it prescribed. You could have injury to another organ while in surgery. You could have urologic problems if your bladder's not emptying or it's obstructed. Or in very, very rare instances, you could have death as a complication from a kidney transplant. Now, I want to let you know about all these complications, not because I feel like they're going to happen, but I want you to know the goods and the bads of kidney transplant before you ever get on the list or before you ever get into the operating room. You really need to know about both sides. So rejection, let's talk just a little bit more about that. That's just meaning that your immune system is acting as your alarm system. So hyperacute rejection, which is again very, very rare, that would happen immediately when they sew the new kidney transplant into your body. Again, we do cross-matching. We feel very confident with a negative cross-match that you will not have a rejection, but they can happen. An acute rejection is a second kind of rejection that can happen, and that would be if it happened within the first couple of months after transplant. Almost always that kind of an acute rejection is reversible. It may require an extra hospitalization and IV fluids and really, really amped up anti-rejection medicine, but almost all the time the acute rejections are reversible. And then the third type is chronic rejection, and these are more changes that can happen, silent changes, small changes that can happen in the kidney over many, many years. And chronic transplant rejection can also cause the kidney to fail. This would be at really, really advising you to get your labs done as ordered by your team, because this is one of the best ways that we know if you're having any signs of rejection or any kind of changes. We really want you to have labs done on a normal basis, on a regular basis, so that we can pick up changes and try to fight rejection as it's happening rather than wait. So what does rejection feel like, and how do we know if you're having it? A lot of times you won't feel rejection, but if you do, it'll be like kidney failure. So you could have fever, flu-like symptoms, you could have fatigue, you could actually have pulse rate changes, you could have pain or soreness at the transplant site, and again, you could have symptoms of kidney disease, like what you had before you ever had a kidney transplant. Blood tests are one of the main ways that we would be able to pick up a rejection episode. If your creatinine was rising, that would be really important to us. If your blood pressure was rising, if your urine output dropped. And a lot of times kidney scans, kidney ultrasounds, and then usually kidney biopsy are done to confirm a rejection, to see what kind of rejection it is and how we should treat it. I want to tell you a little bit about immunosuppressants. These are anti-rejection medicines that you'll have to take for the rest of your life with this kidney transplant. So there's some good things about this immunosuppressant medication. It helps you keep your kidney. There are some downsides that can happen. These are drugs that you will take for the rest of your life. These are going to weaken your immune system's ability to fight off germs. The anti-rejection medications can have their own side effects as well. The doctor will really have to work with you and individualize your treatment plan if you're having side effects, if you're having any kind of side effects that you need to have worked around. Just tell your doctor that you're having side effects so that you can change your dosage of your medications, but never stop your medications. Do not even skip one dose of your anti-rejection medication, because your body never forgets that kidney is not yours. And so we just need to make sure that you always take every dose of your anti-rejection medication as scheduled. There are a few different medications that interact with foods, and mainly grapefruit and grapefruit juice and pomegranate. So please ask your pharmacist and your doctor and your transplant team if there are foods that you need to avoid and if that applies to you. So possible side effects of the anti-rejection medications themselves. You are at higher risk of getting an infection. These anti-rejection medications are lowering your body's immune system and your body's ability to fight germs. So you're at a higher risk for infection, and the highest time of that happening is right after you get transplanted, when you're on the highest doses. Other things that can happen are kidney damage, high blood pressure, diabetes, high cholesterol, cancer, which is very scary to think about. Again, you're going to be taking something that is lowering your immune system's ability to fight foreign things. And so that's one of the reasons why we have you do so many tests before you get the transplant. We want to make sure you don't have any active infections or cancers before you receive the kidney transplant and start taking these anti-rejection medicines. Other side effects that can happen are cataracts, bone disease, joint problems, mood swings, increased hair growth, gum overgrowth, increased appetite, weight gain, stomach irritation, acne, a round face, or what they can call moon face, or flushed feelings. And a lot of these different ones that I was just naming can be caused commonly by steroids. Prednisone is a steroid that is often used after transplantation. It's almost always used while you're in the hospital and while you're in the operating room. And then just depending on your team and their policies and their protocols, then you need to talk to your team and ask if you're going to be on prednisone long term. So good ways to keep your new kidney healthy are watching for any signs of rejection. A lot of times right after the transplant, we'll have patients take their blood pressure, check their weight, check their pulse rate, keeping track of their urine output. These are really important things that immediately after the transplant that you keep records of this and take them to your doctor's appointments. It'll let your team know how you're doing. Taking your medicines exactly as prescribed. Now, sometimes people will think, do I really need to take this 12 hours apart? Do I really need to take it 2 times a day, every day? And you honestly do. A lot of the anti-rejection medication effects only last for 12 hours. And so we want to make sure that you have adequate coverage for your immune system. We want to make sure that you go to your doctor on a regular basis, you get your regular follow-ups and blood work done. You report any kind of symptoms, any abnormalities at all. Sometimes people can be afraid that they're going to call their transplant center too often or that they're going to bug their coordinator or their doctor. You need to make sure that your kidney transplant is well taken care of. Please call your doctor or your team if you have any concerns at all. Stick to your prescribed diet. Again, this is going to be a lot less restrictive than a dialysis diet. Many times you're able to eat and drink almost anything that you want. This will depend on your labs and your kidney function. Ask your pharmacist, ask the dietitian if there's any kind of medications, any special diet restrictions that you do have. And then we really want you to increase your fluid intake, and almost always that's going to equal water. So we really need to bathe that new kidney with lots of water, keep it well hydrated for it to work for many, many years to come. And exercise cannot be stressed enough. In addition to decreasing your adipose or fat tissue, it also will keep your heart healthy and really help with your bones, because bone health is very important after kidney transplant as well. So what else can you do to keep your kidney healthy? Make sure that when you first get transplanted, you stay away from people that are ill and stay away from very crowded places. Make sure that you aren't around people who have contagious diseases or illnesses. When you very first get transplanted, we'd like you to wait before you do any gardening or activity with soil. There's actually some spores, there might be fungus or molds that we don't want you to be exposed to. And ask your team. Most often teams will say not to garden or work in the soil for about a year after transplant. If you have a pet, that's fine. Please do not give away your pet. You can keep your pet, just don't let them lick you on the face. If there's any kind of accidents or any kind of excrement from pets, make sure that your spouse or someone else in the household picks up after the pet waste. Try to avoid any live vaccines and ask your doctor, but this would be oral polio, measles, mumps, rubella, or the shingles vaccine. You need to really tell your team before you start any new over-the-counter medications or any herbals. Some of those things can interact with your anti-rejection medications. So make sure you get good dental care after transplant. Again, that you wash your hands very thoroughly and frequently, that you clean and dress any wounds and let your team know about any wounds or sores that don't heal. Report any kind of signs of infections. Practice good food safety, not eating any kind of things that are raw or undercooked. And make sure that you get all your vaccines that are regularly scheduled and any boosters. For living donation, I want to talk to you about this. Is very important. There are definitely not enough living donation transplants that occur in the United States. So anybody can be evaluated as a living donor if they are very healthy. Many times if they have high blood pressure that's uncontrolled or diabetes that's uncontrolled, then they would not be a candidate, but talk to your team. The person that wants to be a living donor has to have very good kidney health. They have to either have a blood type that's compatible with you, or if you're in a paired exchange program, a blood type that can actually be exchanged with another recipient and donor pair. And to make sure that your living donor is very ready to donate emotionally. There's a lot that goes into being a living donor, and they will actually see the same people as you see, almost all the same tests that you have for your evaluation. For more information about living donation, living donors can go to organdonor.gov. So how exactly are the living donors evaluated? As I said, their evaluation testing is very similar to the recipient. They do have to have ABO blood typing done, HLA or genetic tissue typing done, cross-matching has to be done, screening for infectious diseases, urine tests, blood tests, a history and physical. They do have to see the doctors and the team just like you did for your evaluation. Most often they'll have a chest x-ray, they'll have some kind of imaging of their kidneys, whether it be an ultrasound or a CAT scan. They'll have some kind of heart testing done. Almost always that will include an EKG and an echocardiogram. They will meet with a psychosocial team, whether that's a social worker or someone else. And they also have something that's a little bit different than the recipient, an independent advocate for the living donors. And this is really important so that we make sure living donors are not coerced or feeling guilty or some other reason is actually promoting their sense of duty or their sense of wanting to be a donor. So they have a lot of different testing, very similar to what the recipients do for their evaluation. And we mentioned this before, but if you do have a living donor and their blood type does not match yours, it's not compatible, then we actually can put you on the donor waiting list. We can also do paired exchange at many, many different centers in the United States. They are doing this paired exchange programs now. You can also do chain donations, which would mean that more than 2 sets of organ donor and recipients were actually exchanging. So other than deceased donor listing and paired donor exchange and chain donations, talk to your center. Depending on where you live, your transplant center may be participating in other programs. So what can the living donor expect in their surgery? They'll also have pre-surgery preparation. They will talk to anesthesia teams. They will have surgical incisions. Now this can vary from center to center, but the majority of centers are doing laparoscopic living donation now. And their surgery usually will include 3 small holes, and this is where they will insert the laparoscopic instruments. And then when they actually free the kidney and detach the blood vessels, then they will pull the kidney around and they will pull that kidney, that donor kidney, out of a 3 to 5 inch opening either below or under the belly button after they detach the ureter. Other things to know with living donor surgery, you may also have stitches or you may have staples at the actual incision sites. The length of surgery is usually about 3 hours long. That is an average. That can vary from center to center just a little bit. You will be in the recovery room for several hours before and several hours after the donation surgery. And then the hospital length of stay varies, but it's usually anywhere from 3 to 5 days for a living donor. After surgery, we want to make sure that living donors know that they will get back to regular functioning. At first, they can also have pain and discomfort. They will be sent home with pain medication as well. They are going to have some scarring from the actual incision from that transplant operation. They will have some fatigue, and again, this is usually not lasting forever. This is usually short-lived. They may not be able to drive for 2 to 4 weeks, and that will depend on their surgery and their actual surgeon's advice. Almost always living donors can return to work and regular activities anywhere from 4 to 6 weeks. If they have construction work or anything that's more physical, then it may be longer, more like 3 months. Ask your doctor if you're a living donor when it's safe to exercise, when you can return to work and school, and when you can get pregnant. That's very important to consult with your team before you make any changes. So protect that remaining kidney, and when I say that, I mean any kind of contact sports or any kind of trauma to that area, you want to be very careful where the remaining kidney is. And living donors can also have very emotional ups and downs. This is a really important time of their life as well, and they just have a major operation, and there's a lot of meaning behind being a living donor. So we want to make sure that you utilize the social worker and the living donor advocate and talk to your team about any feelings that you're having. Possible complications of donating a kidney for a living donor are anesthetic-related problems, infections, injury to the remaining organ, bleeding or transfusion need, clotting, reduced kidney function, high blood pressure, if the transplant never works or rejects in the recipient, or death, which is, again, very rare. So just going over one more time disadvantages of transplant so that you know this ahead of time. You could have risks of surgery and complications. You could have risks of infection or rejection, risks of cancer. There's a small risk of other diseases from the donor kidney, medication side effects, stress during waiting on the list and fear of rejection after the transplant, very costly anti-rejection medications that you'll have to take for the rest of your life, and also that Medicare ends after 36 months if you're under the age of 65 and not disabled or have Medicare for some other reason. And then also disability checks based just on end-stage renal disease could potentially end 12 months after the transplant. So you want to make sure that you know that well ahead of time. Talk with your social worker and your kidney transplant team so that you'll know that ahead of time. Definite advantages to kidney transplant include this is the closest to normal kidney function that we have. Dialysis helps with kidney function and cleaning blood and removing fluid and waste, but not on a 24/7 basis like a kidney transplant does. So this is the very closest that we can possibly get to your normal kidney function, the way your kidneys worked before you ever had kidney disease. You're back to a more normal lifestyle, schedule, and medical-wise with the transplant. This may allow you to live longer. This will be the least limited diet. You will probably feel better than on dialysis with a kidney transplant. You'll have less complex treatments. You'll actually have no dialysis unless you have delayed graft function, and then that would be for a temporary time. Other advantages to transplant are that you won't have to wait for Medicare if you're transplanted before your first dialysis or the end of the waiting period. You can live a very good life and a long life with kidney transplant. Hopefully from listening to this program, you've learned the advantages, the disadvantages, that you can get transplanted before you ever have to go on dialysis, that you can have a living donor, whether it's from someone that you know or if you do a paired kidney donation, and to talk to your transplant team with any concerns that you might have. Thank you so much.